welcome to this HUPO Education and Training Committee webinar. This is our Series 3 webinar. My name is Ben Collins from Queen's University, Belfast, and I'm hosting today together with Giuseppe Palmisano. So Giuseppe, do you want to say a few words about the Education Training Committee?
Yes, thanks a lot, Ben. Hello, everyone. So it's a pleasure to be here and opening this webinar series. So I'm chairing together with Justina the Education and Training Committee of the Human Protein Organization. This is a very important committee because we try to advance proteomic research by empowering scientists through education. And what we do actually, we look at researchers at all career stages, and we offer a variety of educational initiatives. Webinars are some of them. So today is the first talk of the webinar series, but we also have workshop, online courses, and also we organize the education and training pre-congress courses at the HUPO. So our main aim actually is to improve education into our proteomic community. And we have also, within HUPO, we have a YouTube channel. So please visit, and there are fantastic talks over there that you can listen to it. By saying that, I would like to thank Ben and our guest, Professor Ruben, and I will give the word back to Ben. Thanks, Ben, for organizing this series that will go all the way until August and will be in this first semester. Thanks a lot.
Thanks, Giuseppe. So as Giuseppe mentioned, we were going to have a series of 6 webinars that will run. Today is the first one with Professor Ruben Lowe, and we will have Professor Isabelle Fournier, Professor Ed Nice, Professor Joshua Labert, Professor Michael Rohrl, and Dr. Adriana Paes-Lim going about once a month until August. So you can keep track of all these events. If you go to the hupo.org, upcoming events, you will see a list of all events. We will also have these announced on the HUPO post and so on. And as Giuseppe mentioned, this is following previous. So this is our 3rd series of webinars. We have a YouTube channel where you can catch up on the videos, where the first series was focused on scientific writing and the second one was focus on technology. So now to today's webinar. So we have we're very happy to have Professor Ruben Lowe, who is an assistant professor of pathology at Stanford University and also the associate director of the clinical chemistry laboratory at Stanford Healthcare. Ruben has a PhD in chemistry from Stanford, very extensive experience in the clinical diagnostic industry, and also a clinical chemistry fellowship at UCSF following this, as well as many awards and invited presentations in the clinical chemistry and proteomics space. So yes, we're very happy to have Ruben with us to open this new series on clinical investigation. In terms of housekeeping, we are aiming for about 45 minutes talk, roughly speaking, from Ruben, and we will do a bit of Q&A for 15-20 minutes after this. So please post your questions throughout the webinar in the Q&A box, and Giuseppe and I will come back at the end to chair this Q&A with Ruben. So great. So with that, I will pass the ball to Ruben. So Ruben, if you're able to, please try to share your screen.
Thank you, Ben. Can you see my screen?
Yes, we just need to go in the presenter view, I guess. Yep, perfect. So I will close my video and mute, and Ruben, the stage is yours. So we look forward to the talk. Thank you very much.
Hey, thank you. Thank you so much, Ben and Giuseppe. And I really appreciate you and also Yanshen to giving me this opportunity to share my thoughts on translation of mass spectrometry-based proteomic research to clinical diagnostic practice. As Ben mentioned, I work at Stanford, the Department of Pathology. I also serve as Associate Director of Clinical Chemistry Laboratory in the Stanford Medical Center. So I don't think I can call myself really a expert of proteomics, but I do spend most of my efforts on launching a clinical test based on mass spec and for protein biomarkers. So I appreciate this opportunity to discuss this topic with the HUPO community, and I also want to learn from you in the Q&A session, like what your thoughts are about this. So this is my disclosure. I have a collaboration with Thermo Fisher and a few other companies. And I divide my talk into 3 sections. So first, I want to talk about the clinical lab environment and what the requirements and guidelines to develop and establish clinical tests. And then I want to share some examples and the stories of applying the innovations of the diagnostic tests, including like the bringing novel proteomic methodologies to existing protein biomarkers, and also some stories of taking the proteomics discovery all the way to have novel protein biomarker testing in clinical labs. And then I'll just do the discussion and Q&A with you. So let's walk into the first section. Let's talk about the clinical lab, how the lab looks like, and what the translational workflow is like. We know proteomics refers to comprehensive study of all proteins in the specimen. It could be a cell, could be a tissue, or even an animal. And in the past, even today, most of the clinical tests on protein biomarkers are focused on single biomarkers. And most of the biomarkers were discovered before the omics time. For example, we use a glycated hemoglobin to diagnose diabetes. So it's like a single marker for the judgment of the single disease. But after proteomics and other omics emerged, the depth of data has increased dramatically. So we can see not only single proteins, we can see a lot of proteins, the entire proteome in the specimen. So scientists have started thinking about, can we use proteome signatures or biomarker panels developed from the proteomics research to use that for clinical diagnostics? That's definitely a great idea, and I fully agree with this concept. However, since 10 years ago, people in the clinical chemistry community have started asking this question. There have been a lot of research done in proteomics and other omics, but where are all the new omics-based tests? We haven't seen much in the clinical labs. And so this article provided a lot of interesting points and thoughts. And my interpretation on that is the major challenges of translation include clinical validation. We need to not only consider the analytical portion of the test or the biomarker, we also need to consider pre-analytical requirements and clinical utility, which means how to incorporate the testing with the clinicians, the doctor's practice, and the disease treatment. And also we need to consider how to adapt the new test and the new biomarker into the clinical laboratory workflow. There are a lot of operational factors to consider that I'm going to mention in the next few slides. So if we think about the clinical test, technical-wise, there's not so much difference from the basic research lab tests, because we just take human specimens and test them in the lab. And the difference is the clinical test is an important piece of the hospital healthcare workflow. And according to CDC, roughly 70% of the healthcare decisions today depend on laboratory test results. So we're proud of that. But on the other hand, we need to always keep in mind that we are part of the hospital service. So we need to incorporate and develop all the workflow and innovations under this scheme. So I list the clinical specimens here. We test mostly body fluid in clinical laboratories, but we also test tissues, especially in the anatomical pathology lab. And for body fluid, mostly blood samples, serum and plasma are kind of a majority part of the samples. I listed here, first I want to show like the clinical specimen-wise, clinical labs are not so much different from basic research labs because we also test like similar samples. But one important thing I want to mention is in the clinical lab, sometimes we cannot choose what specimens we want to test on. one example is for emergency room samples. We want to test for myocardial infarction, the heart attack. Troponin today is the major biomarker for that. And we cannot choose to test troponin in any like samples, like tissue sample. Those typically are not available in the ER. So we have to choose plasma because we even do not have enough time. Most of labs do not have enough time to wait for the blood clotting to obtain serum. So because we want to have a very short turnaround time, plasma or whole blood, okay, they are the major choices of clinical specimens. So we need to keep in mind that the clinical service is a very important thing to consider when we practice new markers and new methods. And looking at the test report, as I mentioned, most of the protein tests today are just single biomarkers. And the mainstream methodologies for protein biomarkers in clinical labs are enzymatic assays and sandwich immunoassays, and plus electrochemical and electrophoretic assays. Mass spec assays are emerging. I personally, I believe it has a bright future, but today mass spec assays for proteins are not mainstream yet. So given these facts, a clinical test must be able to provide a clear and reproducible result. And two, it must be standardizable and transferable between clinical laboratories. And these are actually the reasons why mass spec spectrometry assays are not yet the mainstream, because people are still working on that to get mass spectrometry, the instrument platform, more standardizable and more automated. And also the assays, we need to put more efforts in to make the assays compatible with the clinical workflow. So since we talk about a lab, let's just take a look at what the lab is like. So if you walk into a clinical lab, you probably will be impressed by the large equipment, and there's also a huge. Most labs have a huge automated conveyor belt system delivering the clinical samples to the equipment for testing. And if you look at the workflow, the specimen collected in the hospital transferred to the lab and to go through the automation system, the automation line for testing. So this is what I mean in the last slide. The mass spec is not there yet because we haven't been able to incorporate mass spectrometers into the automation workflow. So most of the clinical labs today put mass spec test as esoteric test. That means it involves manual operation, like sample preparation, sample loading. So most of the labs put the mass spec in a different area or room, have a dedicated team to manage that. But I think the vendors are making great efforts now. So maybe in the near future, we'll see automated mass spectrometers incorporated into these lines. So the hardware side it's like that. And not only the hardware and the assay, we also need to consider some operational factors how to practice mass spec tests in clinical labs. Turnaround time is one thing. As I mentioned, if you want to develop a test for ER emergency needs, then turnaround time is critical. And work shift is another thing we need to consider, because if we want to apply some proteomics tests in the lab, very often we need to involve enzymatic digestion. And if the digestion time is long, it takes several hours, then we need to consider work shifts, because most of the lab technologists work in 8 hours shift, at least in the US, that's the case. So if your enzymatic digest time makes the sample preparation longer than 8 hours, then we need to consider the transition between different lab people on a single test for the same batch of samples. So that can create some uncertainties. We need to be careful of that. And also sample storage. According to our SOP, most of the blood samples are stored in refrigerators. We do have some freezers, but not like that many as the basic research labs. And minus 80 are typically not very commonly seen in clinical labs. So we need to be careful, like if we develop an assay or we need a biomarker that has been stored in like minus 80 freezer, that could be another concern and developing clinical assays. Sample delivery is another thing to consider. We use pneumatic tubes to deliver samples within a hospital, and the courier service to deliver samples between hospital sites. These can cause disturbances to the sample. And also, if you want the serum samples or plasma samples, what the time to do the centrifuge, that's another two things to consider. And we also use standard blood collection tubes, and the tubes have additives. These can cause interference to the test. So all these factors, operational factors, need to be taken into consideration. And the conclusion here is, so the test is not only needs to be standardizable, transferable, and also needs to be robust enough to tolerate all the possible disturbances. So if all these factors are taken care of, then we can go ahead to develop a clinical test if we have some innovation, either on the analytical method side or on the biomarker side. And this review paper published last year has a very good summary of the steps of the clinical lab test development. It has 6 steps here, and the first and half of the second step are supposedly to be done in research laboratory, and the rest all done in clinical laboratories. So I really like this graphic presentation, and I put a single keyword under each step. So if you consider you want to apply, you want to translate your research achievement into a clinical practice, then you not only need to think about the biomarker, how good it is, and how the high performance the method is. We also need to think about the performance in the clinical lab, which is called analytical validation. And the clinical validation is the clinical utility, how the clinician is going to use this method, the test to change their clinical practice. Also, we need to consider SOP, and the quality assurance and quality management is very, very important. How do we keep the test at the same quality for years and for many, many tests? That's a very important thing to consider as well. And also, on top of that, I want to mention one interesting fact in the US, that LDT is allowed in the United States, laboratory developed tests. That's what we call LDT. I know some other countries also have a similar system for LDT. That means those assays developed in the clinical laboratory following clinical lab guidelines can be practiced without obtaining the FDA approval. So that's why currently most clinical LC mass spec assays, including small molecules and protein tests in the US, are LDTs. Last year, US FDA had a new policy to manage LDTs, but this is still ongoing. So we're looking forward to seeing what it's going to go. But so far, LDTs are still allowed and being practiced. And although it's not FDA approved, but like FDA-approved tests, LDTs are subject to inspections by clear deemed accreditation agencies such as CAP. So that's why I want to mention there are things to follow if we have a clinical test using the same technology, that in basic research lab, you may not need to consider these, but in clinical labs, we need to consider the CAP checklists and clinical guidelines. Mostly we use CLS guidelines and CLSI has very detailed guidelines for different kind of tests. On mass spec, there are already 5 guidelines published. And just want to give you an example, the CAP checklist for LDT validation. This is just an example of what to do. It's just like outline, and the checklist actually also provides details to explain what you need to do to follow the checklist. There's another example of clinical lab guidelines. This paper in Clinical Chem summarized the different guidelines and compared them. The CLSI C62A, that's for the mass spec test that was published actually that year, and FDA guidelines, EMA guidelines. So for guidelines, clinical chemists, like we work in the lab, we can choose which guidelines to follow. We can sometimes even develop our own guidelines. But for CAP, for these inspection agencies, we have to follow their checklists. So just want to provide some examples of additional quality considerations that we need to do in clinical labs. So that echoes with this publication in 2014. It's a famous publication by Dr. Carr. He divided like the targeted mass spec test for proteins into 3 tiers. And the clinical test is definitely tier 1. There are many aspects to consider. They are consistent with the guidelines and the checklist that I mentioned in the previous slides. So this is just like to show you in clinical lab, if we want to translate a research test or biomarker and its test into clinical practice, we need to consider the methods, the quality issues, and other like operational factors. So basically, that's about the clinical tests. I definitely I'm happy to discuss more details with you in the Q&A session. And after this, I want to give you some examples of applying the proteomic methodologies to existing protein biomarkers. So the second section. So this is more about just innovation of the technology. It doesn't involve biomarker discovery. And in the next session, I'm going to talk about the successful stories all the way from the proteomics discovery to a clinical lab testing practice. So in the second section, we'll focus on the proteomic methodologies. And in my point of view, there are 2 major approaches or methodologies that we use, bottom-up and top-down. And bottom-up has been more commonly used. And everyone knows that. It's also called shotgun proteomics. We take a protein sample and digest the protein into peptides, shoot into mass spec to do MS1 and MS2. And use the peptide information, we can identify the proteins and quantify the proteins as well. And top down from a different angle, we do not digest the protein. We shoot the intact protein into mass spectrometer and do the fragmentation so that we can characterize the structural features of the intact protein in more detail. And the first example I'm going to share is the bottom-up quantitation of thyroglobulin. So thyroglobulin is a tumor biomarker. So it's a normal protein, but for those thyroid cancer patients, after complete removal of thyroid gland, thyroglobulin should not exist in blood. However, if thyroglobulin is detected in blood, that could mean the recurrence of the cancer. So that's why that makes the thyroglobulin into a tumor marker for those patients. The problem for the immunoassay tests for proteins, which is, again, the mainstream test for proteins today in clinical labs, the problem is 20 to 30% of the cancer patients have autoantibodies. So these autoantibodies can mask especially low level of thyroglobulin. So what happened is the antibodies in the immunoassay could bind to the thyroglobulin without the presence of autoantibody. But if autoantibody is there, they mask the thyroglobulin, the antigen, so it will cause false negative results. So if we apply mass spec to thyroglobulin with the bottom-up workflow, so we digest all the proteins into peptides, then it can potentially solve this issue. So that's why back in 2008, Dr. Hubernagel's team and University of Washington first developed these clinical tests for thyroglobulin using bottom-up approach and with cis-kappa method. So what happened is they digest all the serum proteins and use antibody to capture the proteotypic peptides from thyroglobulin and then do the mass spec quantitation. So this is the cis-kappa method. And they published their results with analytical and clinical validation. They compare with immunoassays with those samples without being impacted by the autoantibodies, and they found good results. And later, more and more publications follow. This is just one example. And it was published in 2022. And you can see the consistency between the mass spec results and the immunoassay results are pretty good for those autoantibody negative patients. And for autoantibody positive patients, you see a discrepancy, which is expected because the autoantibody masks the antigen in the immunoassays. So this is part of the clinical validation of the assay. And they even listed like the patient data on the test, just showing that mass spec has better clinical utility of thyroglobulin test. So the test has been in service for a while. And remember, we talked about we go from biomarker. In this case, biomarker was already there. And then we do analytical and clinical validation in that 6-step workflow. But remember, after the test is launched, we need to assure the quality of the test. That not only means that you need to maintain the quality in your own lab, you also need to consider like how to standardize the assay so that different labs running the same test can provide the same results. And you don't want a patient to get one result in this hospital and going to another hospital testing the same patient and get a very different result. That's unacceptable. So that's why the Dr. Hunego's team and other teams, they spend a lot of efforts on doing the assay standardization, and particularly to find the right reference materials to make the high quality calibrators and to unify the assay calibration. So this publication in 2016 showing like different platforms might give you a kind of different results on the thyroglobulin tests. And after you standardize the calibration, then the difference between different labs becomes much smaller. So it's almost minimized. So this is a very important thing to mention here is the standardization or the quality assurance after the launch of the test is also something we need to consider to provide good healthcare quality clinical lab tests to the patients and for the clinicians. So if we can harmonize the test results between different labs, this will be a very useful thing and a meaningful thing to do for clinical practice. And another example I want to show is the top-down identification of hemoglobin variants that's actually being done in my lab. And we know hemoglobin variants, they are just mutated proteal forms of hemoglobin, normal hemoglobin. And most variants have just single amino acid mutations in the molecule. And traditionally, we use electrophoresis to test the hemoglobin variants. We look at the migration time of the hemoglobin subunits and make a judgment of what variants are there. But given the fact that about 1,500 hemoglobin variants have been reported, using electrophoresis is, in many cases, is not enough. And that's why it gives us the idea, why not we just connect capillary electrophoresis, the traditional technology with mass spec, so that we can just do the CD mass spec measurement of the hemoglobin variants using the top-down workflow. And that's what we did. So we just follow the classic methodology of the top-down. And we first do MS1 analysis. And after deconvolution, we can see the molecular masses of the hemoglobin subunits. And if we see additional peaks somewhere, we know the patient might have a hemoglobin variant. And the intact molecular mass can help us narrow down typically to several candidates of the variants because not many variants share the same molecular mass. And then we can use MS2 to do the fragmentation and to select which candidate of with the same molecular mass match the MS2 fragmentation, and that should be the correct hemoglobin variant. So one example here is this patient is HBF Kuala Lumpur, and we found there's an additional peak, the mass peak between the accurate masses of hemoglobin delta subunit and gamma 1 subunit. So this could be a variant of delta or gamma 1 or even gamma 2. And after checking the database, there were only 2 candidates matched this intact mass, and they are Kuala Lumpur and another one called Port Royal. So if we look at Kuala Lumpur compared to the normal gamma-1, we found the fragmentation pattern matched this mutation, the amino acid number 22 of the gamma-1 subunit mutated from D to G. So we know it should be Kuala Lumpur. And another candidate is called Port Royal. And Port Royal has the mutation here at the amino acid 125, and it's not consistent with the MS2 fragmentation analysis. So we know it's not Port Royal. So confirmed it's Kuala Lumpur. This is just the workflow we applied in our lab. And after that, it took us quite a while to do the assay optimization and the validation. And this is just a partial list of the hemoglobin variants that we were able to confirm using the CV mass spec workflow. And recently, we also upgraded the Orbitrap from hybrid to tribrid so that the sequence coverage can be a lot higher. And we expect to launch this assay in a few months. And we are working closely with clinicians to update their workflow. And also, we're considering after the launch, how do we apply this method across different laboratories and how to standardize that, how to do the proficiency test. So all these concerns, as I mentioned, like for a complete clinical test. Okay, so after these 2 examples, I want to share 2 successful stories all the way from proteomic discovery. So it's not only just applying the mass spec proteomic methodologies. So in these 2 cases, we went from all the way from discovery to clinical practice of the protein biomarkers. The first example is amyloidosis protein typing. So amyloidosis is a group of diseases in which abnormal proteins, mostly denatured and misfolded proteins, they deposit into organs and make amyloid fibrils. And so far, there are about 36 different types of amyloidosis being discovered, and they were driven by like 36 different proteins. And so this is the amyloidosis case. And most amyloidosis happened to heart and the kidney. These are the 2 major organs being affected by amyloidosis. And if it happens to heart, it's also called stiff heart syndrome. And so the most common amyloidosis proteins in heart is amyloid light chain. That means a monoclonal light chain from an antibody, or TTR, transthyretin, B2M, beta-2 microglobulin, and others. And in kidney, most common types are light chain, serum amyloid A, fibrinogen, ALAC2, and ApoA1, the apolipoprotein. And the other proteins could also be found in kidney. And most of the deposit happen in glomerulus. So these are the major challenges that we need to deal with, how to identify these amyloid-driving proteins and those diseases. And the disease was discovered many decades ago. And before the year 2000, tissue staining microscopy was the major tool to identify the amyloidosis. And it was initially like more than 20 amyloid proteins were discovered using the microscopy. And mass spec was introduced in early 2000s, and it helped identify more amyloidosis proteins. So that's the discovery part. And as we know, mass spectrometry, like proteomic methods, can not only identify the protein, we can also look into the structural details of the proteins. So in early 2000s, there were publications showing that in the patient samples, especially for transthyretin, some mutations or variants were found, and they are related to the cause of amyloidosis. And so both bottom-up and top-down workflows were applied, and the work were published by Boston University and Mayo Clinic. And later, Mayo Clinic launched it as a clinical test for amyloidosis protein typing. So these are amazing work just to discover more than just protein and look into the details of the protein causing the disease. And today, a few labs in the United States have this as a standard test, clinical test to help the anatomic pathology labs to identify the proteins. So we first stain the tissue and pick the amyloid deposits from the tissue, and then do the mass spec analysis. To pick the tissues, there were two methods. One is called laser capture microdissection, LCM. We can use an advanced microscopic technology to cut the deposits and put them into a sample vial and do the mass spec analysis, sample preparation. And another method is directly sampling that was practiced in University of Washington. They can just handpick the hot spot from the tissue and then do the mass spec analysis. They involve sophisticated but advanced data analysis to do to remove the interference from other proteins, which is amazing. So we are also trying to develop the amyloidosis test protein testing in our lab to join these labs to offer the test for the mass spec protein typing for amyloidosis. And we follow this classic bottom-up workflow. The small innovation we do is we actually, instead of following the classic bottom-up sample preparation workflow, we use the S-trap workflow to involve SDS as a denaturing reagent, and then do all on-column digestion of the proteins. The reason we incorporate this workflow is we want to shorten the digestion, the sample, preparation, including digestion, into 8 hours. As I mentioned earlier, in clinical labs, if we want to launch a protein test, it will be very beneficial if we can put everything within 8 hours so that we can avoid transitioning of the same sample, same test between different lab technologies. And so far, it's been successful. We are able to achieve this workflow within 8 hours by doing 2 hours enzymatic digestion. And here are some data on the heart samples. And the results we found doing the DDA, and we're also trying DRA workflow, and we can just identify the driving proteins in amyloidosis consistent with the reference test reports. So that's one story of from the discovery to clinical practice. And another story I want to share is phosphorylated tau protein test for for Alzheimer's disease diagnosis. And Alzheimer's disease, it's so famous. I don't need to introduce more. We know it's a type of neurodegenerative disease caused by the damage to neurons in the brain, and particularly what damages. And the hallmark AD pathology includes the beta amyloid aggregates that's deposited outside the neuron cells like these, and the tau aggregates or tau angles happen inside the neuron cells. So these are the hallmarks for Alzheimer's AD diagnosis. So talking about a tau protein, and this is one of the most important biomarker for Alzheimer's. So back in 1980s, scientists have discovered like hyperphosphorylation and modification happen to the tau proteins when they aggregate. So at that time, they were mainly using immunostaining and immunoblotting to just find what post-transcriptional modifications, particularly phosphorylations, happen to the tau protein when they aggregate and damage the neuron cells. And after the year 2000, the mass spec technology, proteomics methodology joined the research and accelerated and broadened our understanding of the tau PTMs, the post-transcriptional modifications. And the mass spec was able to discover 55 phosphorylating sites on the tau protein now. And there were numerous papers published. And one particular paper I want to mention was the Cell paper published in 2020 by Harvard Medical School. They create a map of all the PTMs on the tau protein, and they even compare with the Alzheimer's disease group with the healthy control group. And So amazingly, they could find which phosphorylation and PTMs change dramatically between these two groups. So they kind of like serve as a guide map to clinical assay development, like which markers we can focus on. And so before and after that, the clinical lab scientists have already started to develop immunoassays for particular p-tau, the phosphorylated tau markers for Alzheimer's diagnosis. And first, we use CSF samples, cerebral spinal fluid specimens. And besides amyloid beta, which you might have heard of, the p-tau 181 is particularly a good marker for CSF samples for AD, Alzheimer's diagnosis. And later, we realized that CSF samples, as I mentioned, when we develop clinical assays, we need to consider like the specimen restrictions. CSF samples are available, but not easy to obtain as peripheral blood samples. So there has been constantly a demand to transfer CSF tests to plasma, to blood tests. And so more blood tests were being reported on p-tau 181. And later, based on the mass spec work and proteomics work, scientists realized there's a different p-tau. p-tau 217 has particularly better performance in plasma. And we can see the raw curve. These are raw curve analysis. We use the area under curve to judge the performance of the biomarker. So the p-tau 217 has a significantly higher AUC, area under curve, compared to the p-tau 181 and p-tau 231. So later, p-tau 217 has become the major testing biomarker in plasma for Alzheimer's disease. And you may think after the discovery of the p-tau 217 and also other p-tau proteol forms, mass specs maybe will not be used because the immunoassays can measure these single proteol forms. However, this story actually tells you maybe not, because mass specs also has particular advantages in quantifying these proteol forms. So there were publications by Dr. Bateman's lab in Washington University. They developed mass spec assays for targeted quantitation of these p-tau proteol forms using PRM and parallel reaction monitoring. So using PRM, we not only we can detect and detect the different proteol forms of the p-tau, we can also characterize where the phosphorylation happens and differentiate these different p-tau proteol forms, because we know there are 55 possible phosphorylations in the same protein. So this is very important because this can guarantee the highest specificity of the test. When we test for p-tau 217, we know it's exactly p-tau 217 if we use the mass spec methodology. And since 2023, there have been numerous head-to-head comparisons of the test, including mass spec and the immunoassays on different p-tau markers for the Alzheimer's diagnosis using plasma samples. And we found the mass spec methods is always slightly better in terms of the AUC compared to other methodologies and other biomarkers. So I think one of the explanation is the specificity that mass spec provided that cannot be achieved by traditional immunoassays. And on the right side, the graph also shows the CSF and plasma consistency of the p-tau 217 is very good. So that actually makes a real clinical impact. So what happened is in June last year, the Alzheimer's Association revised their criteria for Alzheimer's diagnosis and staging. And as we can see here, in plasma, p-tau 217 is the only biomarker for Alzheimer's disease diagnosis and the T1 staging. So that's an amazing achievement of translation of this proteomics discovered biomarker into clinical practice. And now many labs and many vendors are developing the assays to serve the neurology department in the hospital, as we know, because two drugs have been approved for Alzheimer's disease treatment. So the test demand has been increasing rapidly. And also, I want to mention there, the A beta, amyloid beta 4240, they were very good biomarkers in CSF, but actually not very effective in plasma. So thanks to proteomics discovery work, we now have a very high performance biomarker p-tau217 in the clinical lab in our toolbox that we can use to help neurologists treat Alzheimer's disease. So with that, I want to make a summary. The key factors to bring proteomic research discovery to clinical diagnosis, we need to consider many things. So analytical performance and clinical utility is the number one thing, but that's not all of it. We also need to consider the compatibility with clinical lab workflows and operational factors, including robustness and standardization. And the crossroads of mass spec-based proteomics and the clinical mass spec applications include, of course, very importantly, biomarker discovery. That's the key factor we need from the mass spec based proteomics research. But I think a very important question to ask here is how to select the potential biomarkers for clinical validation, because we see many papers of proteomics research published and showing there are a lot of potential biomarkers. And in clinical labs, many of the markers are not here yet. So which ones should we prioritize to validate? And that's definitely something I want to discuss with the HUPO community today after the talk. And also mass spec automation, that's a very important thing to help incorporate the mass spec-based proteomics into the clinical testing, because we don't need to set it as an esoteric analytical tool. It can be a routine test platform that a lot more validation work can be done on the automated mass spec platform. And the last but not least, collaboration between basic research and the clinical laboratories is very important. I see like the good thing is more and more academic hospitals have established a mechanism to accelerate and encourage collaboration between the basic research and clinical practice. So that's a very good sign of for the future. And in the end, I want to acknowledge my colleagues at Stanford Pathology Department and my research team. And our clinical lab, we have great technologists working with us on developing new assays, and my collaborators, CMP Scientific and Thermo Fisher. Okay, so that's the end of my talk, and I would love to take questions and have discussions. Also want to learn from your thoughts of the clinical translation of biomarkers.
So thanks very much, Ruben. Ruben, I think we lost your audio in the last 10 seconds there. Can you say something again?
Oh, I'm sorry. Yeah, so
Giuseppe, do you hear Ruben?
Hey, Giuseppe?
You hear him?
Yes,
I can't hear him,
hear.
so maybe something is wrong with my audio.
Yes.
Yeah, so that's I want to acknowledge like my collaborators and my team.
Ben, I think, can you hear us?
So I'm having a problem with my audio. Giuseppe, I don't know if you want to take over maybe and start the Q&A, and I try to fix it.
Sure. Thanks a lot, Ruben. It was a fantastic talk. There are two questions in the Q&A. I don't know if I can read it from you. So the first one says, whole blood, like red blood cells, you do lysis, centrifuge, capillary electrophoresis, and then you do the top-down MS analysis. It's really powerful in its simplicity. How many proteins, in terms of primary sequence, do we think may be accessible by this approach? So how many proteins do you think we can identify using this approach?
I see. So my understanding, this question is about the hemoglobin test.
Yes.
Yeah, so in this test, it's a little special because hemoglobin is the dominant protein, in whole blood. So we actually didn't need to do much preparation to remove other proteins because hemoglobin, if we just dilute the sample and the major peaks, actually this is actually the TIC or total iron electrophoregram. And the peaks are just only like showing the hemoglobin and no other proteins. But I do understand this question. So if we want to test for other proteins, I think in clinical labs we would follow the basic research workflow, and I think we need to deplete the high abundance proteins if we don't want to like analyze those high abundance proteins, so that we can reduce the interference to show the medium and low abundance proteins. And one thing I also want to mention is in clinical labs, because we have particularly high requirements on the quantitation, reproducibility, and accuracy. So that's why Dr. Hufnagel's lab, they have the cis-kappa method, which is very helpful because this, after digesting all the proteins, we use antibody to capture the proteotypic peptides. So this will make the background very clean for the next mass spec quantitation step. So for low abundance proteins, I would highly recommend that doing purification either before or after digestion. That will be very helpful for developing a clinical test if we want to translate biomarkers into clinical practice.
Ruben, if I
Okay, great.
may ask, Ben, can I ask just a follow-up question
Sure.
regarding the hemoglobin variants? Do the hospital normally ask some validation at the genetic level? So once you find all of these variants, do they normally ask for genetic tests to validate that?
Yeah, that's a great question. So today, we do have a workflow that we use the traditional electrophoresis test. And then if we do need confirmation, we send out either like in-house, we have the beta subunit genetic test, or we send out to other labs for alpha and the gamma delta gene sequencing test. But the issue is, so far we didn't talk about like reimbursement and like payment issues, but as you know, the healthcare budget is becoming tighter and tighter. So genetic testing today still costs more than like the other kind of protein tests, even mass spec tests. So that the result is only a small percentage of the samples qualify the genetic testing based on the regulations and the payment schedule. So that's why in many cases, we still have to rely on the traditional test results to make the judgment. And that's why we are, the clinicians have a strong demand for us to launch a mass spec test, which is faster and in the same lab, because we do the test just traditional and mass spec in the same lab, give a quick turnaround time, a report. And not only that, all the samples they have any suspect, they can send for us because the relatively lower cost. And also technically, there's one advantage of using mass spec compared to gene sequencing. Although in most cases, gene sequencing can tell the same result. But what if there's like PTMs happen to the hemoglobin? I don't have the slide here to show, but we did have a case. It's called a hemoglobin rally. And the rally is a mutation of the first beta subunit from valine to alanine. And that mutation simultaneously incorporates acetylation on the first amino acid that causes interference with hemoglobin A1C test. So the patient actually had diabetes, but could not be diagnosed by A1C. So using mass spec, we can easily tell there's acetylation happened in the first amino acid that explain the discrepancy of the diabetes test results. And gene sequencing does not give you the PTM information. So that could be a little like technical advantage of using mass spec compared to gene sequencing.
I actually also had I was also fascinated by the hemoglobin example. Maybe I can quickly ask, you can resolve many more variants now with the mass spec compared to the capillary electrophoresis, right? And I'm just wondering, how does this map onto, do all these variants map onto different, slightly different disease states? Do you know this mapping very well? Like how actionable are all these variants in terms of clinical outcome?
Yeah, so the hemoglobin variants, they are congenital disorders. So it's like mutated in the gene. So
Yeah.
it's germline, yeah, mutations. So talking about actionables, this is a great question because we actually had an internal discussion why the hematologists want to figure out exactly what the mutations are there. So there are two types of needs. So type one is the mutation is not silent. That means it causes symptoms. Sometimes could be severe symptoms, sometimes mild symptoms, but there are symptoms. So for those mutants variants, the clinicians want to know exactly like what the root cause is. Say if the patient has anemia, is it because of the hemoglobin variant causing anemia, like mild anemia, or it could be some other underlying disorders there that they need to further diagnose to find out to help the patient keep healthy. And another case is those are silent variants. So the variants do not cause any symptoms when the patient's healthy. But in that case, it's still good to know what like the mutants are, because if one day the patient has some hematological disorder and they need to take treatment like medications that affecting the hemoglobin, the red blood cells, then if the hemoglobin is mutated, in the red blood cells may have different like mechanical rigidity to like the drug. So they have different reactions to the drugs, and the hematologists need to be aware. Like for those patients, they need to adjust the treatment plan. So no matter what, having more information of the hemoglobin variants is always, helpful for clinicians. Unfortunately, still most labs today are just heavily rely on the traditional methods. So many patients we see in the history, like we know the patient has hemoglobin variant, but we don't know exactly what the variant is. That's the current fact. So I hope this can improve that.
Fantastic. Okay, let's go to the next question. So there's one question about using clinical proteomics to track disease progression. So I guess this is maybe longitudinal type of measurement. Do you have a comment on this?
Yeah, like Alzheimer's disease. So this is a very hot topic today in clinical chemistry and in laboratory medicine field, because in theory, there are two needs, like people above 55 years old should take screening for Alzheimer's, because Alzheimer's is not a very low prevalence disease for senior people. And number two is there are already FDA approved drugs. So we can treat patients now. But how do we monitor the test? That was actually that's why I really highly appreciate the development of proteomics, because if without knowing the map of the PTMs, the phosphorylations on the tau proteins, there's no way for us to pick the right biomarkers for monitoring. Because again, I want to mention here is CSF was traditionally used because in the past, if there was no drug, no active treatment, then you don't need to test Alzheimer's markers all the time. You just basically take CSF sample at the beginning to confirm the diagnosis. That's it. But now you have the drug for treatment. Then how are you going to monitor the treatment efficacy? You cannot take CSF all the time. It's a very painful procedure and it's hard to obtain the samples. Plus peripheral blood, like for plasma samples, is a lot easier. And that's the biggest motivation to push from CSF tests to plasma tests. And again, proteomics, not only mass spec, but mass spec was definitely a key role in this proteomics development to find these different options of the p-tau biomarkers. And then fortunately, we found one. Actually not we, is the scientists found one, p-tau 217, and it can be tested by either mass spec or immunoassays today. So it looks very promising. And in our hospital, we are in the process of establishing a p-tau 217 test in the clinical lab, so that we are also working closely with the neurologists to incorporate that into the Alzheimer's treatment workflow. So back to your question, the proteomics workflow, I think this is very important. We should not say mass spec is the only way, but it's definitely a very important way to provide an overview of the proteome or the map of PTMs. And I would say in the future, more and more cases like the PTOM would happen in clinical labs, and it will happen like more rapidly. Especially people are talking about AI now, so I don't know. Maybe hopefully machine learning and artificial intelligence in the future can help us pick and more quickly validate the clinical like new markers. And this is yeah, I think there's a bright future on that.
Great. Giuseppe, do you want to take one, or shall I continue?
Yeah, there is one actually from the chat. I was looking now. So Ruben, they are asking if you could comment on glycoprotein detection using MS for clinical samples. I guess, I mean, antibodies are some like type of glycoproteins.
Yeah, this is a great question. So glycoprotein has been a hot topic, especially for tumor diagnosis. Actually, in the lab currently, in our lab, we like other labs, we test those like carbohydrate antigen CA series of proteins. These are heavily glycosylated proteins for tumor diagnosis, and that's just like the common practice. But I think there are much more potential there for glycosylated protein testing, especially looking at the glycosylation pattern. And there have been many reports on that. And in our lab, we're also working on a project I didn't have time to share today, but we are looking into the glycosylation pattern of the myeloma protein that's related to the disease multiple myeloma. That's also a hot topic in tumor like research. So hopefully, and there have been publications by other labs showing the potential of just using the glycosylation itself as a marker to help risk stratify the different patient groups. So that's one example. And I think as a single person, I cannot cover all these research achievements that made, because there are rapid research that's going on. But if you search online, I think there are a lot of promising glycoprotein markers there. And then the second half of this question is how do we the testing of glycoproteins in clinical samples. So that's a very interesting topic, because I don't want to spend too much time on that, but I want to mention is my personal point of view is mass spec will become a very important tool for testing the glycosylation, because if we do traditionally we run most protein tests on immunoassays, but immunoassays, when it goes to the glycosylation pattern, in many cases, it's not very effective. And we typically don't have antibodies against a particular glycans. We can use lectins, but the specificity could be another concern. So mass spec, as what we practice now, we found mass spec is a very, very powerful and efficient in just characterizing the glycosylation of the proteins. So I do think mass spec will play a very important role on that in the future.
Then may I ask a follow-up question on that? Yes. Actually, there was one slide, in the introduction, where you mentioned that in order to develop a clinical assay using MS, normally you need an internal standard that needs to be labeled just to add to your sample. Now, thinking about the glycopeptide, which the chemical synthesis is not so straightforward, how do you foresee that step, or if it can be done in a different way?
Yeah, that's a great question. And actually, the internal standard problem is not only for glycoproteins. For other proteins, I think there are, some assays are affected by the lack of internal standards. So I think there are like two types of tests: identification versus quantitation. So identification, probably we can have some ways to bypass the strong need of the stable isotope labeled internal standards. But for absolute quantitation, I think it's a little bit hard to bypass that in clinical tests, especially if we want to have very high accuracy of these tests. So as far as I know, there are not many like options now. We kind of just expect like in the future, the stable isotope labeling technology will become better, so the proteins can be synthesized. And more protein markers now, we have seal proteins to serve as internal standards, so that can go through all the sample preparation procedure with the analyzed proteins. However, for glycosylation, to be honest, yeah, this is a great question, and I don't have a strong answer on that. I don't know if it's a good idea to try the cell culture method to grow the glycosylated protein. It might require more technologies to make the protein like really like the analytes.
Great. So maybe one question on the biomarker discovery side. There's a question asking about, do you have a favorite, or could you comment on plasma protein depletion protocols? What do you think is best, or do you have some experience there?
So in general, in the mass spec, in clinical mass spec field, we actually, not only for proteins, also for small molecules, we like me and like my peers, we used to discuss, we just divided them into different levels. And so again, it's general, including small molecules. So we do protein precipitation. That's for small molecule. That's probably the lowest level of the purification method. And then we can have SPE, SLE, and LLE. And the highest level is antibody capture. So I think if we put the like top 14 protein depletion, like albumin depletion, these technology in, they are more like the protein crash method for small molecules. So so my point is the highest level is always like antibody capture. And if we want to work on like medium or low abundance proteins, currently I think maybe the antibody capture is almost the best way to do the sample preparation. Yeah.
But I guess for antibody capture, you need to know the target, right? And if you're at the biomarker discovery stage, then you don't have this choice necessarily. Like if you're into the clinical chemistry stage, then this sounds very good. But is there any comment on the discovery side, or is that something you've worked on?
Actually, yeah, probably not, because I still view myself as a learner and to the pure proteomic research. So, but I've seen like more and more publications with like modified workflows, and I think these are amazing technologies. One thing I want to mention, I think it was by Dr. Inger's group in Wisconsin Madison. They used like nanoparticles to capture. So that's amazing. It's just, without using antibodies, yeah, nanoparticles could be maybe another way. Yeah, and I think some companies also trying to use nanoparticle technology just to concentrate low abundance proteins. Yeah, I'm looking forward to see more technologies like that.
Maybe I can sneak in one question myself before we finish up. I'm curious about the idea of like multi-analyte measurements in the mass spectrometry versus ELISA world. So in the earlier days, people would sell the idea of targeted mass spectrometry because you would be able to relatively straightforward way set up multi-analyte measurements and have panels of proteins that would be informative. And now maybe these days multiplex ELISAs are also reasonable, but can you have a comment on multi-analyte and whether these are penetrating into the clinic? Are they useful? What are the best technologies, let's say?
Yeah, exactly. That's a great topic. I can, yeah, I just want to try to be concise because we actually had a lot of discussions and thoughts on that, within our community. So I think first of all, if we want to treat the the multi-analyte test, like in the classical way of developing clinical assays, then it's a little bit hard to do because we need to treat every single marker as a single biomarker. For example, we need to have an internal standard. for every single one. So if I go back to, yeah, this slide, like the paper from Dr. Tarr's group, like, yeah, it says like we need to, yeah, label internal standard for every analyte, and for every biomarker, we have to validate them as a single biomarker. So that actually dramatically increased the workflow, with the workload, because let's say you have one sample. If you want to validate one single marker, you just focus on this marker and do like you know, like 100 or 200 samples just to confirm its performance. But if you have a panel, then that number will be a lot bigger, because you have to guarantee all the analytes are accurately quantified within one sample. And if some like one out of the biomarkers did not work well in this test batch, then you have to discard the batch and just run that again. So basically, I think it will require a lot more efforts on developing multi-analyte assays. So that's why it could be one of the obstacles in the past, and not like that's why we're not seeing many clinical multiplexed clinical panels there. But on the other hand, I think the future is actually is the situation has been improving, and the future is brighter now, because first, the analytical technologies have advanced a lot in the past several years. So I think the quantitation of multiple analytes, the performance is much more reliable. And two, there could be other alternatives. So I'm thinking about, like, for example, even for multiplexed immunoassay, so we can combine like mass spec with immunoassay and utilize the advantage of both, because immunoassay does not require internal standards. And so, the performance, it does not need to consider the ion spray ionizations, like efficiency variation. So if we combine these two, it could be a potential solution for multi-analytes. And also, we can also maybe learn from the gene expression profile, because in the genetic testing field, gene expression profiling is not a very new thing. It's happening there for like several or even more than one decade in the clinical diagnostics practice. So there are some methodologies and data analysis approaches that we might be able to borrow from gene expression profiling to do the protein expression profiling. So I need to look into details. I don't know much about gene expression profiling, but I do think there's something that we can probably borrow from that to, like, to ease our workflow, instead of just focusing on every single biomarker. There should be like data analysis approaches to help us to like reduce the workload of validation, like all the biomarkers in the panel.
Okay, fantastic. So I think we're getting a little bit over time. Maybe I will suggest that we can wrap up there. So let me thank you very much again, Ruben, for joining. I think this was very informative for the proteomics community to understand what the real constraints are at the other end, and but also very nice to see the breadth of technologies and the breadth of kinds of measurements, not just protein quantities, but variants and PTMs and so on. This has been super informative for us. So thank you very much for joining. Thanks very much to the audience for joining, and for those who didn't make it, they can catch up on YouTube soon, I hope. Maybe I will just remind people that the next instance of the webinar series will be on 27th March with Professor Isabelle Fournier. And with that, I think we can close the webinar. So thank you very much, Giuseppe and Ruben, for joining.
Thank you so much, Ben and Giuseppe. I really appreciate it.
Thanks a lot. Thanks a lot, Ruben. And
Many thanks. Bye-bye, everyone. Thank you.
Bye.
Bye.